Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. It takes a special kind of emotional strength to be a hospital chaplain, bringing comfort to patients and families who desperately need it. Claudia Hubbard, she needed that strength for both her job as chaplain and as well as 2 breast cancer diagnoses. The second diagnosis was actually a side effect from treatment for the first one. Today, we'll explore that irony when a cancer treatment ends up causing another cancer. And we'll see why the second round of treatments were particularly tough to deal with. Claudia Hubbard is here with us in studio, along with 2 of her doctors here at the University of Kansas Cancer Center. Hello to all of you. Kelsey Larson. Dr. Kelsey Larson is a breast surgical oncologist, and Dr. R Stecklein is a radiation oncologist with a special focus on breast cancer. So again, so happy to have all of you here on this Monday. Claudia, I want to start with you. We mentioned 2 different diagnoses. Tell us about the first one that happened back in 2014.
The first one, I was really fortunate. It was detected with a 3D mammogram, something that wasn't standard in those days. It wasn't even covered by my insurance. I had to pay an extra $50 to get the 3D.
Right.
Best $50 I've ever spent.
Well spent, for sure. Had you been getting regular mammograms
Absolutely.
from back in the day, as we say? So things had changed as far as the different types of further testing you could do. But what was it like when you heard that you were diagnosed with cancer? What was that like for you? What action did you take?
It was, what action did I take? First of all, I immediately started and, okay, what are we going to do about this? And the word cancer is a hard word to hear in connection with your own name. And I had to literally practice in front of a mirror saying, I have cancer, before I could go and tell anyone else that I had cancer.
You said it out loud to yourself?
Yes.
That's very interesting. I could see where that would be helpful, just the reality of it, the gravity. So you went to work to get treatment. It involved a lumpectomy plus radiation. And Dr. Larson, statistically, how effective is the combination of both of those treatments?
Sure. So we call lumpectomy plus radiation breast conservation. That's the umbrella term for that treatment. And breast conservation and mastectomy are actually exactly equal in terms of recurrence and survival, particularly for early stage breast cancers. So we consider breast conservation to be the standard of care, the gold standard for people with small and early stage breast cancers, like how Claudia had initially.
So that would be like the first line of defense. That's the route you would go first. Dr. Stecklein, jump in on your thoughts on that.
So we've been doing breast conservation since the 1970s. Before that, the standard was a mastectomy, which is still done today in appropriate circumstances and still represents an appropriate surgical option for many patients. But breast conservation allows women to have a much smaller surgery, a much faster recovery, and to keep their breast, which is both cosmetically favorable for most patients. They get to keep a sensate breast. They don't have the same sorts of issues that they have after mastectomy, and studies overwhelmingly show that women who are candidates for both mastectomy and breast conservation, their sense of well-being, their quality of life, all of those kind of things that we can measure that are important to patients beyond survival are better with breast conservation.
So Claudia, you hear this as an option. How did you feel about your treatment?
I thought it was an excellent option. Obviously, no woman really wants to have a mastectomy if it's not absolutely necessary. And I was fortunate. I was right on the edge when I first started having talking to Dr. Mitchell then about the radiation. It was going to be a 6-week protocol, and right when I was needing my radiation, it was changed to best practice was 3 weeks. So I had a reduced protocol of radiation.
So how was recovery overall?
It was fine. I continued to work. I went to work every day, came to the radiation center after work, got my quick little radiation treatment, and went about my life. A little fatigued, but in general, it was not a really big deal.
It wasn't a big deal. You go on with life, but then we fast forward 5 years later. You were getting your regular follow-ups, being a good patient, doing what you're supposed to do. How did you learn about this second diagnosis?
I started to have discoloration on my breast, and actually the first medical person I saw was Lori Rinaldo, who's a lymphedema specialist. And since I was seeing her, I thought I'll just ask Lori about this. And she immediately keyed in on it, knew something was wrong, and took me from her exam room right over to meet Dr. Larson and her team, and had a punch biopsy within an hour.
You said discoloration. Can you be more specific about what you mean by that?
Kind of a purplish color.
How long had that been going on?
Maybe a couple of months, but getting progressively worse. At first it was like, am I really seeing this? I'm not sure. By the time I met with Lori Rinaldo, it was fairly pronounced.
Any other symptoms? How were you feeling?
None. My breast was heavy.
Gotcha. Okay, so this new cancer was an angiosarcoma. Dr. Stecklein, in Claudia's case, it was caused by the radiation from her first treatment. Tell us a little bit about that.
Sure. So we have known for a very long time that radiation-associated angiosarcoma is a rare but serious potential side effect from radiation for breast cancer. The best data we have is from a study that was done in the Netherlands, and they looked at almost 300,000 women who'd received or not received radiation, and they were able to very clearly show that the risk of that is about 1 in 1,000 8 years after treatment. So that means we have to follow 1,000 patients who we've given radiation for 8 years to find one case of angiosarcoma.
So very rare, but is anyone who gets radiation then monitored in some fashion for that, or are they just told to look for discoloration or other symptoms?
So they should be. Again, we mentioned that during our consent process where we talk about all of the things that can happen during radiation. Again, we note that it is an exceedingly rare event, but it can happen. And that's really one thing that we look for when we do long-term follow-up for patients who've had radiation, is any of these skin changes that can be suggestive of something like a radiation-associated angiosarcoma.
And that's the primary symptom somebody might see?
Typically, it's exactly what Claudia described. It's a purplish, reddish discoloration of the skin. Sometimes there's a mass, but more often it's just this kind of appearance, change in color of appearance of the breast.
Which is why when Claudia came in, they knew exactly to send her to Dr. Larson. So this angiosarcoma, very aggressive, it spreads. You call it sneaky and tricky. Why?
Yeah. So angiosarcoma is a bit of a challenge, especially from a surgeon standpoint, because we can't see where the cancer cells start and where they end. So like how Dr. Stecklein and Claudia were saying, it spreads out and it infiltrates throughout the tissue, so you can see an area of discoloration, but often the area of the actual cancer cells are beyond what we can see. And particularly with angiosarcomas, because they are a little bit more aggressive in terms of the risk of recurrence, we need to get very wide surgical margins, meaning a wide area of tissue all the way around. So in the operating room, to our eye, we can measure out and we can take what seems to be 5, 6, 7 centimeters of margin all the way around, but yet when we get the pathology back at a microscopic level, there can be cancer cells that are infiltrating much farther than what we can see.
Well, and because it's so rare, I guess we don't do this all of the time. Does that make it, does that make it harder to detect when you're not doing this on the daily?
I think the biggest thing about that is, as Claudia was saying, it is rare, but someone knew exactly what it was and to act quickly when they saw it. And
it is time of the essence with a cancer like this.
Absolutely.
We know it's aggressive.
Absolutely. And that really highlights, I think, the need for the whole team. So part of what we need with all of our breast cancer patients is really good survivorship care. And so that's something, not just your treatment team, but then once you're done with your treatment, making sure you're doing your follow-ups, like how you're so diligent, and having a really good survivorship team that notices this isn't right, we need to act promptly.
So Claudia, you previously had the lumpectomy, but how many more surgeries were you required to have?
Well, I had the mastectomy with the new diagnosis, and then we did 2 follow-up surgeries after the mastectomy seeking the clean margins, which we were not successful in getting. And that's when I met Dr. Stecklein.
So tell us a little bit more about the need for those continued surgeries to make sure those margins are cleared.
Sure. Every type of cancer has different margin widths that are optimum or ideal, meaning different rim of normal appearing tissue around the edge of the cancer that makes sure it's safe from a recurrence standpoint. Sarcomas are ones that require multiple centimeters, and so we always start when we do a mastectomy with making sure that we can get the incision closed, but then if we have a closed incision and we still need to take out more tissue and get more margins, we have to go back again, but again we're blind to how much to take. So we try to go in a stepwise fashion, trying to take out a little more and a little more, wanting to get that clear margin, but also wanting to make sure that ultimately the incision can be closed with the help of our plastic surgeons rotating and bringing in some new tissue.
And actually, I came out of my first margin surgery with a wound vac on my chest because the wound was so large that that was what was required to help it heal.
And explain what that is for folks listening.
I'm going to let one of you describe. I can describe it, but
You do such a good job, though, of explaining it from a patient standpoint. What did it feel like, look like?
well,
What were you told about it?
it's a suction device that actually pulls the wound closed gradually so that it can heal from the inside out. And it was applied to my chest. There's a pump unit that comes with it, connected by tubing that pulls the extra fluid off. So I had an appendage to my body for a while. After several weeks, we were able to move to a smaller wound called a Pravina that was less bulky and more comfortable.
She knows what she's talking about.
Yeah,
like
she
we don't even
definitely
need
does.
doctors
I know.
here, right?
We'll use the wound vac sometimes. So I believe originally when we were working with each other, as best we could see, this measured around 10, 11 centimeters in size. And when all was said and done, we were about 25, 26 centimeters in size. So a big difference about what we can see and what it actually was. So we'll use the wound vac sometimes as kind of a temporizing measure to make sure we're getting those clean margins from a cancer standpoint, keeping her safe while we're waiting for that pathology to come back, and then using it as a stepwise fashion for the plastic surgeons who will then rotate tissue in to get everything covered and healed.
So you endure multiple surgeries, find out the cancer is still there, you needed radiation again. Dr. Stecklein, normally radiation sessions are once a day, five days a week for several weeks, but you proposed radiation 3 times a day. Why?
So Claudia had again, very unique clinical circumstance, and the challenge in her case is that her chest wall had already been radiated before, about 5 years before, and we still had sizable deposits of cancer that we had to treat. And so that means we have to go to a pretty high dose to eradicate every last cell that's there. This concept of doing radiation multiple times a day, we call it hyperfractionation, meaning we chop the radiation up into many, many small doses rather than giving bigger doses once a day. And the primary benefit of that, at least theoretically, is that it can reduce late side effects. Now, it's not going to do anything to mitigate acute side effects, as Claudia can attest, but it does reduce the likelihood of severe late tissue complications, at least in theory. So this regimen that I used in Claudia's case was developed by the University of Florida, and it's called HART, hyperfractionated accelerated radiation. So we get lots of radiation dose in, but we chop it up into tons of small doses to try and keep it as safe as we can for her.
So with her unique case, you knew when you, after meeting with her and meeting with the teams, that this was a very specific type of treatment plan for her.
Correct. The other way people sometimes approach this is with something called hyperthermia. We don't have hyperthermia at KU. There are very few centers in the US that do, and that's what it sounds like. You heat up the tissue and then you give it a dose of radiation, and it basically causes the same effect. It sensitizes the cancer cells to the radiation, but can make the normal tissue effects worse as well.
I want to take a look at some of the images you brought of Claudia's treatment plan. What are we seeing here?
So this is a 3D rendering of kind of a frontal projection of Claudia's body when we did her radiation planning scan. And the structure you see in green are the incisions from her mastectomy and her multiple kind of margin surgeries to try and clear that margin. As Dr. Larson mentioned, angiosarcoma is sneaky. We need to get wide margins of treatment around that. And so in Claudia's case, we took a 2-staged approach, and we treated everything that was within 5 centimeters of that green structure to high dose, and everything that was 10 centimeters, that was the larger blue cloud, to a lower dose of radiation, kind of assuming that the highest risk of cancer cells is close to the incision, but there's still a risk further away from that. And so we, in a sense, are substituting for a surgical margin with a radiation margin.
So Claudia, Dr. Stecklein explains this treatment plan. You're going to be doing this every day, 3 times a day. How challenging was it, or were you up for the challenge?
Well, it was my best option, and it was challenging. When Dr. Stecklein first told me about it, and also I believe I was the first patient here at KU to have that done, I looked around the room and I said, so how do we do this? I can't go home and come back. Do I pack a lunch and come for the day? And indeed, that's pretty much what I did. I would arrive at about 7:15, 7:20 in the morning. We would start the therapies quickly after that, and they had to be spaced at least 4 hours apart. And so I would be here until 4:30 or 5 in the evening. And I will say the clinic was amazing. They set aside a treatment room for me. It had my name on it. It was reserved. one of the nurses scrounged up a recliner because when I first started, there was a straight chair in the exam table for all day long. And so we found a Lindsay found a recliner, brought it in for me. I would bring my lunch and
hunker
spend
down
the day.
Yeah. Well, that's so interesting to hear. But yeah, I think we need a plaque or something on that.
We've talked about that. We need a more Claudia Hubbard, honorary treatment room. That recliner is still in that room.
Yes.
Yeah.
I love that, starting a trend.
Yeah.
So again, going back to that treatment, because being very, very specific with those beams, this is a photo of that, and this is very specific. Explain what we're looking at.
So this is just one representative slice of Claudia's treatment plan, and again, she'd had radiation before, so I wanted to avoid as much as possible radiating tissue that had previously been radiated. And Claudia's angiosarcoma and her primary breast cancer were both on the left side of her body, and we know that patients who have left-sided breast cancer, we need to be really thoughtful about avoiding radiation dose to the heart to avoid long-term cardiovascular side effects. So this is an image of something we call intensity modulated radiation therapy, and so we came up with this really elaborate geometrical orientation of a number of different beams that allowed us to shape the radiation dose to the area we needed to target and keep as much dose off of heart and lung and all of the other things that we don't want to radiate as possible.
Very cool image to see how that's going to work in there, and again, how precise that is. So Claudia, you also brought some photos to really show us how tough this was on your skin. And before we do show them, we just want to give a warning to viewers. Claudia and I spoke about this and said they were a bit graphic. You agreed as well.
Yeah.
But you've been so open about sharing your story and kind of how this has affected you, some of those more acute side effects. So let's see what we're looking at first. So what is this burn? It has an appearance of a burn. Tell us what we're seeing.
It is the effect of the radiation. And
this is post-mastectomy.
This is post-mastectomy, post those 2 margin surgeries. And during the month-long treatment, my skin, my tissue was really looking good. And it wasn't until a couple of days later when I thought, well, this was not such a big deal, that this process started. And my entire left side of my chest was pretty much an open wound.
So that was not from the mastectomy, that was from the radiation.
Yes.
I want to bring that picture up again if we can, because Dr. Stecklein, this is not technically a burn where you would maybe end up on a burn unit. It looks like a burn, it feels like a burn, but technically no.
And we would, in a sense, treat it like a burn. And so when we give radiation therapy, there's actually no transfer of heat energy to the patient whatsoever. What we're seeing here is the result of interfering with Claudia's stem cells in her skin being able to replenish themselves. So all of our tissues in our body have stem cells that continuously renew those tissues. The radiation puts those to sleep in a sense. And so when we do that continuously over a month, the normal cycle of renewing her skin can't happen. And so she ends up with this large wound because she just doesn't have any skin to cover that area.
I want to show a photo of some stitches that went down your bicep. What are we seeing here, Claudia?
After multiple plastic surgeries, my skin was not able to heal. It wouldn't hold. And so Dr. D'Souza, who was my plastic surgeon, took a flap of skin from my inner arm, and it was really important that that flap of skin be continuously connected to a blood source so that it was alive and viable. And she brought that over to my chest in order to give us some tissue that had not been irradiated to help the healing process. That was very helpful, but was not the final surgery that I needed, because I still had some places that would not hold. Dr. D'Souza would even put extra things in to help the incisions heal, and they would just start pulling apart again. And so ultimately, she took a flap from my back, from the latissimus muscle.
Oh, let's show a photo of that while you're explaining.
And pulled
that,
it
please.
over. And that is...
Can we pull that photo up? It's the final photo. This is what you're talking about, right?
So that is, and especially the part that doesn't look red and irritated, that is the tissue from my back. So it had never seen radiation therapy. And we did that, and then a skin graft on the top part of that.
So many working and moving parts with her case. What makes it so interesting? Tell us a little bit about that, because when I reached out to you and said, find me a really great, interesting patient that we can profile, you said, I've got Claudia. And so tell us why she stood out so much and what was so interesting about her case.
Well, I think that Claudia's treatment really highlights what patients like her need from beginning to end. And I was mentioning about the survivorship team before, recognizing something was going on. You need the surgical oncologist to, do their work with the cancer radiation, the cancer treatment. But as you said, you also had plastic surgeons, you had pain management physicians, you have wound care physicians.
Yes.
You had all sorts of people that needed to come around and provide you that support. So sometimes what happens with patients is they get with one of us as a surgeon or as a radiation oncologist, and we might be the face of their team. But really what people like Claudia highlight, I think, is how the whole support system within the whole health system is needed and necessary to provide great care. And also she was so impressive because she has such a positive attitude and such a wonderful spirit. She's certainly someone who stands out just from that as well.
So, and then you ended up retiring because of this, or taking a step back from your duties as a chaplain at Children's Mercy. Was that hard to do or just necessary?
It was both. I retired soon as I had the diagnosis. I realized that I was nearing retirement anyway, and that's not. I only had so much to give at that point in time, and I needed it to be in terms of my recovery. And so I opted to retire. When I learned about the 3 times a day radiation therapy, it was like, I don't think I could have done this.
Yeah.
But it was hard. I loved what I did. It was important to me, and I felt like it was important to the patients and families I worked with. And yet I knew that it was time.
And just briefly, you were telling me about a conversation you and Dr. Stecklein had. Tell me a little bit about that, about this. This isn't just about dealing with and bearing the treatment and the pain.
Yeah.
Tell us a little bit about that conversation.
I think, again, because of the work I had done, and I was actually the chaplain for the oncology unit at Children's Mercy, so I'd had some experience with families who were in the midst of devastating diagnoses. And I know and knew then that it was really easy with the intensity of the therapies, with the emotional impact of it, that it's really easy to get focused only on the disease and on the treatment and to lose sight of the person who is behind all of that, and the fact that the treatment and the therapy, no matter, or the diagnosis and therapy, no matter how intense they are, that's only a small part of who someone is. And so to hold on to that essence of who someone is so essential. I was really fortunate. I had a wife who totally understood that, who helped me stay grounded in a lot of other ways, helped normalize my life in the midst of living at the clinic for days on end. But it's that, I think, is so easy. I've seen so many people over the years who their entire life becomes about the diagnosis and the treatment.
Thank you for sharing.
And there's so much more.
It's shifting your perspective.
Yeah.
If you have questions you'd like to ask, use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. That info is there on your screen. Let's get a quick check on our COVID account with Dr. Dana Hawkinson.
Yeah.
Good morning.
Hi.
Hey.
Happy cold Monday.
Yeah, right?
Unfortunately, yeah, we are into fall now. Right now, at the health system, we are holding somewhat steady, 17 active infections. We've been in that 15 to 20 range for some time now. So 17 active, that's good. We haven't gone up above that at this point in time, but obviously with the colder weather, we know that even more people will be inside doing things and getting together in those enclosed spaces. Certainly, we know the virus is out there circulating in the community.
All right, Hawk, a new study tried to answer the question, how much protection do COVID vaccines give against long COVID? So this paper was published in, here I go, I'm going to try this, Antimicrobial Stewardship and Healthcare Epidemiology.
Yeah.
So long story short, 2 vaccine doses cut the risk of long COVID in half compared to the unvaccinated. But Hawk, this study was a meta-analysis, so tell us exactly what does that mean?
Yeah, so a meta-analysis is a type of study where you take other studies, whether case series, which are just a bunch of cases about patients and taking that data together, or things such as randomized control trials. They are basically looking at all kinds of the studies and then putting them together and trying to analyze all of the data as a whole. And that's what this one was. This one took about 24 different studies, starting from December 2019 to June of 2023. It looked at those that were infected or uninfected and vaccinated or vaccinated. And what it showed was that there was about more of a 32% vaccine efficacy against long COVID for those people that had received 2 doses of vaccine. But if you are up to date on your vaccination, meaning you've received at least 3 doses, there was about a 70% reduction in the risk of getting long COVID. So we know long COVID does affect many people on a daily basis. This was looking at really vaccine efficacy against or protecting against that risk of long COVID. And it showed that, yes, if you had 3 doses or more at any time before or after infection, you did have that reduction in long COVID symptoms. Now, again, the major caveat being is still the definition for long COVID is broad. We are working on a significant or a specific definition for that, but it is easy to determine that people have symptoms. They obviously know their body, but that is the one caveat to this study, is really the definition of long COVID.
All right, Hawk, thanks so much.
Yeah.
Let's get to some questions from our viewers. And Jean, one of our viewers, says that, just a comment, what a brave patient and elaborate and innovative treatment. So thank you for sharing, and thank you, docs, for sharing how we got Claudia getting better and back to life. So Leslie wants to know, how often do patients get radiation more than once daily? I mean, how often are you using and implementing that plan?
So Claudia's plan, again, she was the first, and I don't envision having to use this anytime in the near future. We do somewhat frequently give radiation twice a day. That is used frequently for some patients with inflammatory breast cancer. It's still the standard of care for patients with something called small cell lung cancer. And then we often will use it or consider it in cases where we're giving a second course of radiation, again with the idea of reducing the likelihood of long-term side effects. So twice a day, not terribly uncommon. 3 times a day is almost unheard of.
And Claudia, how great was it to work with Dr. Stecklein and be the first? Very few of us get to be the first at anything.
Yeah. I was a little staggering to think, okay, you really have done this, right?
Yeah, there's
But
that,
I also knew he was very upfront about talking to me about being in constant contact with Dr. Mitchell, I believe it was, in Florida. And so I felt really well supported and very grateful that I had the benefit of living right here in Kansas City and having KU Med and the Cancer Institute at my immediate disposal.
Yeah, you were in good hands.
I was, and I felt really good about that.
Just last question. From Sarah, can surgeons see cancer when operating?
So we can't see individual cancer cells. Sometimes we can feel a mass or feel some change in the tissue, but we cannot see individual cancer cells, only under the microscope.
So Dr. Larson, I'm going to stick with you.
Okay.
Get our takeaways today. What's the big takeaway from today's conversation and Claudia's story?
I think my big takeaways are why I brought up Claudia is a couple things. Every person deserves a team around them. And it's not just your surgeon or just your radiation oncologist, just your medical oncologist. It's the team that gives patients great long-term outcomes and also works with them during their treatments to manage those symptoms. And like I said, I think Claudia's positivity and just the light that she has about her makes her a really unique person that I wanted to honor and tell her I was appreciative that she was my patient.
Well, thank you for helping bring her to the table today. We appreciate that. Patients don't do this alone, and nor do our physicians. Our specialists have to work together in tandem. Dr. Stecklein, what's the big takeaway today?
I want to echo what Dr. Larson said. Claudia dealt with this entire thing with such grace and humility, and she went through hell and back. And I am, at this point, she's far enough out, very, very optimistic that this thing is gone forever and never coming back.
Yeah.
All right. Thank you, Dr. Stecklein. So Claudia, wrap us up. What do you want folks to take away from your story?
The importance and huge benefit that we have KU Cancer Institute right here, and the team approach. I had so many people helping me get through this, not just the medical, but the support, the bringing in a recliner when you need it, and things like that make a huge difference when there's so much that has to be focused on the treatment and the hope for a cure.
Thank you so much for being with us and sharing your story, just being so open.
Absolutely.
Thank you. Thanks to all of our guests. Thanks to our viewers for being with us today. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. I'm Jessica Lovell. On the next Morning Medical Update, accepting your new body while fighting breast cancer or after surviving it can be a battle in itself. Our patients share the emotional journey and how the care teams here guided them. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.